Acute respiratory distress in children is characterized by breathing difficulties marked by changes in the rhythm and amplitude of breathing, accompanied or not by signs of struggle. It is a common emergency situation in pediatrics that requires rapid and appropriate intervention to ensure the health and safety of the child. A positive diagnostic criteria for acute respiratory distress in children include changes in respiratory rate such as polypnea and bradypnea, as well as signs of respiratory struggle such as flapping of the wings of the nose and intercostal drawing, which mean the retraction of the spaces between the ribs during breathing, in addition to cyanosis, which is a bluish discoloration of the skin. Severity diagnosis involves evaluating various signs and symptoms that indicate the severity of the situation. Signs of asphyxia in a child in respiratory distress include generalized cyanosis, tachycardia, defined by an increase in heart rate in response to hypoxia. Arterial hypotension can also occur due to hypoxia, as well as some excessive sweating and impaired consciousness, ranging from confusion to loss of consciousness. Signs of exhaustion include bradypnea, which is characterized by a decreased breathing rate, indicating advanced respiratory fatigue. In addition, the disappearance of sign of respiratory struggle is observed, marked by the cessation of visible respiratory effort. The etiological diagnosis of respiratory distress in child involves the identification of the underlying causes that contribute to the appearance of the respiratory disorder. During the interview, it is important to take a medical history to identify possible contributing factors. This includes looking for conditions such as bronchopulmonary dysplasia, a chronic lung condition often associated with prematurity or prolonged mechanical ventilation in newborns, malformations, and cystic lung disease, as well as cystic fibrosis, which is a genetic disease mainly affecting the respiratory tract and digestive system. A history of previous respiratory infections are also an important element to consider in the differential diagnosis. The evaluation of the mode of the onset of the symptom is of a great importance in the diagnosis. A sudden onset of symptom may suggest choking syndrome caused by inhalation of a foreign body into respiratory tract, while gradual onset with fever may indicate a respiratory infection. It is also essential to assess child's immunization status to determine if they are up to date with their vaccination, as some vaccines preventable disease can lead to respiratory complications. Associated digestive signs such as vomiting, diarrhea, or abdominal symptoms should also be considered, as they could indicate gastrointestinal origin of the respiratory distress. Additionally, the presence of gasp, shallow, jerky breathing observed in children in advanced respiratory distress attempting to compensate the lack of oxygen may provide additional information in clinical assessment. For a complete assessment of respiratory distress, several additional examinations may be necessary. Chest radiography can confirm the underlying mechanism of respiratory compromise, such as pneumonia, pleural effusion, or airway obstruction, while looking for the presence of radiopaque foreign body. Blood gas analysis provides essential information about the severity of respiratory failure by assessing the level of oxygen and carbon dioxide in the blood. The infectious assessments, including complete blood count or CBC and CRP or C-reactive protein, makes it possible to detect signs of inflammation and identify the potential infectious agent through a bacteriological or viral sample. Finally, a bronchoscopy to see the interior of the lungs and airways using a thin flexible tube equipped with a camera, which is valuable for searching for foreign bodies, assessing the extent of lesion, and guiding the appropriate treatment. Now let's talk about the cause of the respiratory distress in child, which is divided into several types. For obstructive dyspnea presenting signs of marked respiratory struggle, one of the possible etiologies is the obstruction of the airways at the level of the larynx, mainly during inspiration. The etiological direction vary depending on the age of the child. In children older than 6 months, several causes can lead to this condition. Subglottic laryngitis, usually of viral origin, is the most common and occurs gradually during or after nasopharyngitis. Supraglottic laryngitis, although rare, is a serious condition characterized by an open mouth and a hyperextended head position with an increased risk of cardiac arrest. Aggluttic laryngitis can be caused by pathogens such as diphtheria, leading to the formation of false membranes on the vocal cords. Finally, the presence of a foreign body in the respiratory tract can lead to the penetration syndrome. In infants younger than 6 months, several other causes of airway obstruction may be considered, including subglottic angina, an abnormal growth of blood vessels in the subglottic region. Similarly, a retropharyngeal abscess characterized by accumulation of pus and the retropharyngeal space can compress the airway and cause breathing difficulty. Congenital laryngeal cyst, as well as laryngomalacia, a congenital malformation of the cartilaginous structures of the larynx, can also lead to airway obstruction in infants. The diagnosis of these conditions is often confirmed by medical imaging techniques or endoscopic examinations. In the case of tracheal obstruction, where respiratory difficulties are present during inspiration and expiration, several etiologies can be considered. First, the presence of an inhaled foreign body can partially or completely obstruct the trachea, leading to difficulty breathing in both respiratory stages. Additionally, compression of the trachea from a nearby tumor or abnormal vascular arc can also cause airway obstruction, leading to difficulty breathing. In the case of bronchial obstruction, where the respiratory difficulty is mainly expiratory, several etiologies are possible. First, bronchiolitis in infants, a common viral infection of the lower respiratory tract, can lead to the narrowing of the small airways, causing difficulty breathing mainly when exhaling. In addition, asthma can also lead to the narrowing of the bronchi, mainly during exhalation, which makes breathing difficulties. Finally, the presence of an inhaled foreign body can obstruct the bronchi, also causing breathing difficulties. In the case of polypnea with mild signs of struggle, several etiologies are possible. First of all, pulmonary damage may be involved caused by pleural effusion such as pneumothorax or pleurisy, as well as infectious pneumonia, which can lead to an increase in the respiratory rate without necessarily causing obvious signs of respiratory struggle. In addition, cardiac damage, whether congenital or acquired, such as heart disease as well as myocarditis, can also induce an acceleration in the respiratory rate. Finally, neuromuscular or partial conditions such as a respiratory paralysis due to neurological diseases or chest trauma. In case of respiratory amplitude abnormalities without signs of struggle, various presentations may be observed. Hyperpnea, characterized by rapid, deep breathing, can occur in situations such as dehydration, shock, acute anemia, fever, or acidosis. Conversely, oligopnea, corresponding to a decrease in respiratory amplitude, can be observed in neurological conditions such as head trauma, meningitis, or encephalitis, where impaired respiratory control can occur. The treatment of acute respiratory distress in children includes several approaches. Symptomatic treatment aims to improving ventilation and ensuring adequate oxygen supply. Placing the child in a half-sitting position can make breathing easier by helping to clear the airway and ensure that their upper airways are clear to facilitate breathing. Oxygen administration may be necessary to maintain adequate oxygen levels in the blood. In cases of severe respiratory distress or hypercapnia characterized by an accumulation of carbon dioxide in the blood, intubation or mechanical ventilation may be necessary to ensure effective ventilation. These measures aim to stabilize the child's respiratory conditions and prevent possible complications. The etiological treatment varies depending on the underlying cause. For subglottic laryngitis, it is generally consisted of the administration of corticosteroids and air humidification. If the response to initial treatment is insufficient, hospitalization may be necessary for close monitoring and more intensive treatment. In the case of epiglottitis, it is essential to keep the child in a sitting position and not to lie him down. Emergency intubation may be necessary to maintain the airway, accompanied by antibiotic therapy to treat the infection. For diphtheria laryngitis, antibiotic treatment and corticosteroid may be given to control the infection and reduce inflammation. In the presence of a foreign body, immediate extraction is essential to restore normal breathing. Finally, for other respiratory conditions such as pleural effusion, pneumothorax, treatment may include clearing the nasopharyngeal tract, administering bronchodilators to facilitate breathing and draining the effusion if necessary. hope these informations were helpful to you, and I hope to support us by subscribing and liking this video. Thank you so much for watching until the end, and I'll see you in the next one.